Okay. Hello, everyone. My name is Nev Jones, and the title of my presentation is Psychosis, Coercion, and Civil Commitment, a Harm Reduction Approach. I just want to start with an acknowledgement that the harm reduction framework that I will be spending most of this presentation talking about was developed collaboratively with Leah Jacobs, who's another member of the faculty here at the School of Social Work at the University of Pittsburgh. And we have a forthcoming chapter that the tables that I'll be including in the presentation are being fully articulated in. And that is going to be part of the volume Abolitionist Social Work published by Haymarket. Okay, so just to introduce this topic, a few just sort of more empirical notes or kind of highlights on what we know about psychosis and coercion. So studies that have looked specifically at the experiences of young adults who have experienced a first episode of psychosis not only find extremely high rates of coercive intervention or an involuntary treatment, but in some cases, several studies have actually documented not just that kind of coercive intervention happens, but that it is experienced as so traumatizing that over half of individuals with FEP in the samples that have been examined would actually fully meet DSM-4 criteria for PTSD on the basis of the coercive responses to the initial psychosis that they experienced. If you look at the literature on adult involuntary commitment, study after study after study, you'll see higher rates of psychosis or schizophrenia in terms of who is being involuntarily hospitalized. So one way we could think about this is that adults with psychosis relative to the prevalence of psychosis are significantly overrepresented among those who end up involuntarily hospitalized. And then in this space, race and psychosis powerfully intersect. So I have a couple of references below, all of which are in the final slide of the PowerPoint. A recent study looking at Black and Caribbean origin youth in Canada with early psychosis, documenting substantially higher risk of coercive intervention. And a recent systematic review and meta-analysis, which aggregated studies from all over the world looking at excess rates of coercion among different ethnic racial groups, found that across countries, Black and Caribbean origin individuals were compulsorily or involuntarily admitted to hospitals at 2 to 3 times the rate of white individuals. In some studies, for instance, one from London in the UK, found that increases were as high as 16 times the rate of excess compulsory admission versus voluntary for white clients. So kind of powerful racial disparities playing out in this space as well. Why? So this is a little bit more speculative. Why do we see so much sort of overrepresentation of psychosis and then really kind of intersecting with race? So, first of all, we know that stereotypes, stigma about psychosis have increased rather than decreased in the past decades, even as stigma vis-a-vis other mental health conditions has markedly improved. The sociologist Bernice Pescosolito is really kind of a leader in this space, conducting epidemiologically sampled studies of the general public in the United States. And really powerfully documenting increases in stigma towards individuals with schizophrenia who are described in vignettes as having or experiencing schizophrenia. And this is tied to dangerousness and fear and desired social distance then on the part of the participant. Some of Pescosolito's work has also specifically looked at media reporting on mass shootings that widely attribute shootings, as well as just kind of violence more generally, to quote unquote mental illness or psychosis or schizophrenia, establishing a direct correlation between such reporting and worsening stigma in the United States. I think we can also pretty easily see how the particular stereotypes that are associated with psychosis or schizophrenia, dangerousness, aggression, unpredictability, also really map onto gender and race-based stereotypes, particularly about the perceived dangerousness of Black men. So Black man with schizophrenia, you're going to be subject to really kind of this powerful intersection of stereotypes and racism. And that alone could explain a lot of the responses that we see, and again, kind of excess rate of coercion. Then another kind of influence in this space, I think, is clinical discourse around quote unquote lack of insight and or anosognosia. It remains very influential in the way we have come to think about psychosis in clinical spaces, in the way that clinicians, including counselors, social workers, psychiatrists, are trained. And I think what this emphasis, especially on kind of biologized constructs of anosognosia, which position lack of insight as a fundamental feature of the quote unquote disorder, really in clinical practice lead then to kind of an overexpansive dismissal of concerns that patients or service users may be kind of bringing to the table, and really kind of undermining more egalitarian, person-centered communication in which concerns are taken seriously, and people are kind of treated as the authors of their own stories. Another thing that we see in the psychosis space that, you know, that would be, I think, often quite different if we were talking about suicidal ideation secondary to depression or anxiety in youth, for example. We see really powerful escalating conflicts around medications. So antipsychotics, primarily I'm thinking of here. And interpretations of the nature of the experience is in question. And these kind of escalating conflicts around kind of who defines what is happening, and how seriously to kind of engage with concerns around antipsychotics and, you know, antipsychotic discontinuation, I think often leads to family members, other third parties, clinicians contacting crisis services and or 911, and that kind of kicks off a chain that often culminates in civil commitment, involuntary hospitalization. There is quite a bit of evidence actually demonstrating with very powerful convergent methods, including detailed qualitative analysis, ethnographic observation of psychiatric consultations, that even among psychiatrists who are ostensibly well trained in recovery orientation and shared decision making, that short and long-term side effects of antipsychotics are regularly downplayed. Less documentation, but I think ample anecdotal evidence at first-person accounts, right, documenting how this plays out in families. I want to emphasize that this is not a judgmental comment. I think families often end up seeing antipsychotics as sort of the solution and have very few other resources at their disposal and kind of don't know what to do, and kind of society, and most importantly, kind of clinical systems and clinical leadership, research leadership have kind of provided people with very little deeper education or alternatives. And these dominant approaches, I think, to engaging with people very rarely support true person-centered and person-driven care. So I study early intervention and psychosis programs, have been working in this area for almost 15 years. Very, very in-depth, detailed work with programs all across the country. In the absolute best cases, we really see, I think, kind of person-centered care that is not the norm, even in a space where the quality of care overall is far higher than what we see happening in kind of status quo community mental health services, public sector mental health services. For instance, if a young person comes in and is offering a totally, different alternative explanation, whether that is tied to cultural beliefs, whether that's tied to trauma, whether that's tied to, I don't have psychosis at all, but I do have drug-related problems, those alternatives are really kind of rarely supported as then the kind of the central framework through which the clinicians or the team works with the young person. Instead, it often becomes a conflict and a fight, and or an assertion, sort of a structural and interpersonal assertion of the frame, the nature of the problem is psychosis, period. And really the only alternative is for young people to leave. Quite a bit of my work has documented rates of kind of unilateral client withdrawal or service user withdrawal and disengagement from best practice early intervention and psychosis programs. And in a way, as per usual, we see not only very, very high rates of disengagement. Average in the US is about 50% before reaching 12 months in what is designed to be 2-year programs. And then racialization of disengagement. So the very highest rates being among young Black men. And to what end, to what do we accomplish by the sort of these dominant approaches to psychosis, to antipsychotic adherence, and to over-reliance on coercion? So there is actually little to no evidence that involuntary commitment or on the outpatient side, assisted outpatient treatment or compulsory treatment, in fact, increase engagement over the long term. And much evidence that coercion, in fact, systematically undermines buy-in and may increase the risk of suicide post-discharge. I am linking to research articles in top journals by leading researchers in the area. On AOT or compulsory treatment orders, I just want to reference a cost effectiveness analysis by Simon and colleagues in 2020. To quote them, CTOs, and so that's the kind of international term for what we call in the US often assisted outpatient treatment. CTOs are unlikely to be cost effective. No evidence supports the hypothesis that CTOs decrease hospitalization costs or improve quality of life. Future decisions should consider impacts outside the healthcare sector, such as higher informal care costs and legal procedure burden of CTOs. In California, with the care courts right now, this issue and debates around it are alive and well. And more generally, if we want to think about, okay, why is it there is a fantasy, there's a clinical fantasy, there's a fantasy we might engage in family members, and certainly I have in the past, right? That by controlling people, by controlling the situation and by controlling individuals, that we will get the outcomes we want. And often we think of that as saving people, that this is the only way to save somebody that we love, in the case of family members, right? Or to save somebody that one is clinically invested in from a provider perspective. I really think of that as a fantasy that comes from a very, very well-intentioned, committed place that is kind of engages in a kind of fundamental error about kind of human nature and how autonomous motivation, in fact, develops or is undermined. So there is extensive, really, really extensive evidence from the self-determination theory literature that in general and specifically in mental health care contexts, Coercion and external pressure actually rather systematically undermine the development of autonomous or self-directed motivation. If what we want is individuals who are engaging with whatever behavior it might be because they want to on their own terms, in general, coercion and external pressure are among the best ways to undermine that. So, kind of the convergent point here is deeply sympathetic to people who find themselves overwhelmed by what they're seeing in an individual experiencing psychosis. Completely empathetic and have experienced this literally my entire life as somebody with great depth of experience and exposure, not just personally to psychosis, but in very close family members and for whom I was and have been responsible. The fantasy that we are fixing that by forcing them into a hospitalization, forced injections, AOT, that's where I think we really err. Okay, the consequences are some of the worst outcomes for psychosis in the world. We see unemployment rates above 90% for individuals diagnosed with schizophrenia in the United States, extreme overrepresentation among those who are unhoused on the streets and in jails. So this approach that we have taken for decades and decades, which is premised on paternalism and control, I would submit to you is not working. Empirically is not working. The evidence we see is incredibly high rates of disengagement from the system and people who end up effectively receiving no supports at all, who don't trust providers and don't want to engage with them. And my commitment to psychosis is to address that. We fix the problem through more coercion. So that's where I'm coming from, fully acknowledging the complexities at play here. So the approach I now want to kind of articulate and advocate for is a harm reduction approach, which, following Andre Gore's, we could also call a set of non-reformist reforms. So just a couple of kind of quotes here. Mariam Kaba, I believe in the use of every possible tool in our toolbox. How do we reduce coercion and support people and regain or sustain trust and relationships and build relationships and support people to develop their own motivation and intentionality in living their lives? And then to quote Andre Gortz, who coined the term non-reformist reforms, he was a socialist. This is not a mental health, this is not written in a mental health context, but to quote, fears of co-optation under any circumstance reflect fossilized thinking, a lack of strategy, and theoretical reflection. On the assumption that partial victories within the system would inevitably be absorbed by it, an impenetrable barrier has in fact been erected between present struggles and the future solution. The road from one to the other has been cut. The movement behaves as though the question of power were resolved once we're in power, but the whole question is precisely to get there, to create the means and the will to get there. How I'm applying this here, and how Leah and I have applied this in the kind of the work that we've done together, is an orientation really to debinarizing kind of debates around involuntary commitment, not approaching this as an either or, that one sort of just, with the sweep of a pen could possibly just sort of abolish involuntary intervention, or on the other side, just sort of a uncritical defense of kind of paternalism and coercion as this kind of solution to the problem of psychosis, which is what we see in the care courts, for example. So the framework is kind of really thinking about how do we not only reduce harm where involuntary hospitalization is occurring for a variety of reasons is occurring, and it happens, all around us every day, probably tens of thousands of people across the US involuntarily hospitalized on any given day. So how do we reduce harms there, but not in a kind of simplistic reformist sense, in a way that is really kind of shifting our thinking about what's happening and shifting clinical culture? A caveat in terms of what I'm going to talk about today is that I'm really kind of focusing on actions and principles of practice at the level of providers, social workers, clinicians, peer specialists, as the case might be, some of which have really fairly obvious structural correlates, but I'm not talking about structural change in that sense here. My imagined audience, if you will, is really kind of clinicians working in this space. And what I'm thinking about is kind of what tools and what shifts in thinking can real world practicing kind of clinicians and providers take up kind of in the name of harm reduction. So principles, and I know I'm actually sort of violating the principle of too much text on a single PowerPoint slide here, but I did so intentionally because I think it's also kind of helpful to see things together, and these PowerPoint slides will be accessible on the website if you want to kind of go back and read through. So First principle, transparency regarding policies and procedures. So at an absolute minimum, where we're not in a position to actually change policies and procedures. So let's say you're a social work and you are expected to follow various kinds of mandatory reporting protocols within your agency, et cetera, et cetera. Nothing in general prohibits you from being as transparent as possible with clients or service users about those policies and procedures. So example, this would include full transparency about policies such as reporting individuals to police departments in states with so-called red flag gun laws. It would include full transparency about involuntary hospitalization protocols at the agency and what is entailed. Does the agency call police for transport? Is there third person transport? So all the different pieces of it, being very transparent the minute a service recipient, a client, kind of comes in and first engages and is onboarded into a program. And then I think taking it one step farther, openness and transparency about the individual provider's perspective and positionality. Realistically, a lot of the clinicians and social workers that I work with and have trained as faculty in a social work program are very, very critical and very sensitive to the potential harms of involuntary hospitalization, but feel paralyzed and concerned about clinical boundaries, and so don't open up to clients or service recipients about their own concerns. And I think that's an area where we can really do more to be more transparent, more respectful in an interpersonal sense, in the sense of a respectful relationship where both parties are actually sort of sharing where they stand rather than kind of not talking about things, avoiding certain topics, or kind of hiding behind a cloak of objectivity, neutrality, or agency policy. Second principle, shifting away from adherence/abstinence thinking. And here, in a way, this is classic harm reduction on the drug use side. So that this, kind of, binary around stopping, kind of withdrawal from all quote unquote illicit substances or street drugs, right? That there's sort of no in between. Is really, really problematic. And there's so much evidence, of course, on the drug use side in favor of harm reduction. And so here we're kind of applying it as a more general principle. So a deeper embrace of clients' kind of freedom and autonomy to make a variety of decisions regarding the use or discontinuation of both prescribed medications and street drugs, not making it an either or. Many clients, I think, individuals with lived experience of psychosis use antipsychotics as PRNs. That should be encouraged and supported rather than either you take it every day and are perfectly adherent or you're non-adherent. So again, this kind of openness to kind of in-between strategies and strategies that kind of people have found to work for themselves. Third, validation of clients' explanatory frameworks. Huge amount of my work has focused on that, right? So really, really acknowledging that if we want 50 to 70% of our clients to unilaterally withdraw, then we can kind of continue with this kind of a single framework approach to this is what psychosis is, this is what you're suffering from. We have these techniques and these strategies and these medications, and really a radical reorientation to if the goal is to meet people where they're at, we have to actually meet them where they're at. We have to actually seriously engage with the kind of the explanations, narratives, and stories they're bringing to the table. And if we don't, the status quo will continue. So really, really important there. There is no, well, I shouldn't say there's never agency policies that militate against this, right? Because in programs with a more manualized approach, there may be aspects of kind of the manualized treatment that even require handing out psychoeducation sheets. But I think the vast majority of programs I work with, there's no rule, and this is a doable thing. I think that's what I want to emphasize. This is not pie in the sky thinking. This is actually doable to kind of shift clinical practice and framing in this way. Third or fourth, validation of structural violence. Really, really acknowledging, and this is for clients really kind of from across the spectrum who have experienced social and structural racism, poverty, how they may have been treated in the child welfare system, in kind of income-based benefit welfare system, subsidized housing projects, et cetera, et cetera. So a lot of structural violence happens to folks who are Black and brown and poor in this country, right? And I think there's a real risk because of the way that clinicians are trained to kind of think, to focus on individual psychology, that even if it doesn't kind of explicitly downplay and minimize what people are facing in kind of structural terms, it de facto or indirectly does, because we're not putting the focus there. So, kind of examples is just kind of people, when they hear about the poverty somebody is experiencing or has grown up experiencing, really, really validating and acknowledging that as a form of deep social injustice in this country. Really engaging in conversations about how that has shaped somebody's lives, shaped their perspective, and shaped their entry into social systems and mental health systems. And I interview people all the time, so I just want to say, I'm not imagining that this doesn't happen. It is so rare to talk to a client or service user who says, yeah, that's the kind of conversations or dialogue I have with clinicians, and that's been true across the different agencies that I've worked with. So I think it's doable. It may not be happening in a very widespread way. It is doable, it's achievable, it's not pie in the sky. And then accompaniment. So if we assume, for instance, that somebody has been involuntarily hospitalized, we can think about accompaniment in the sense of really kind of walking with and beside clients in their journeys through and across a crisis, even if involuntary hospitalization occurs. And, here there may be some need to, for example, refuse institutional kind of incentives or requirements to reduce contact with clients during a period of involuntary hospitalization, and really kind of pushing for spending more time with them at the hospital. Kind of, picking them up when they're discharged and kind of really kind of a very different, visibilized, embodied kind of commitment to being with that person during a difficult period. So these are the general principles, and this is like a relatively short presentation, and so I'm not going to go into a lot more detail. I also don't believe in being prescriptive in general. So, I think the idea here is start thinking about these kinds of principles, these kinds of shifts, and that's really what I would kind of promote and push for. Next, just some specific strategies and practices across the crisis continuum. So this is just a little bit more of an attempt to flesh this out specifically around prevention, crisis intervention, and postvention. So assuming crisis intervention sort of escalates into an involuntary or civil commitment here. So use of threats. When I interview folks about involuntary commitment experiences, unfortunately, one of the most common things that one hears is that they are threatened at multiple points, both in the hospital and before they get there. And often there are threats of police involvement, even when police never get involved. Now, just think about that for a moment. Is it appropriate for somebody experiencing who has not engaged in a criminal act, somebody who is experiencing distress or kind of psychological crisis, to respond by saying, if you don't comply, I will call the police? I mean, that sends a very, very kind of problematic message, right? So just across the board, eliminating threats about escalation, eliminating threats about putting people in seclusion and restraints, et cetera, et cetera. Blame and shame framing, another thing that one hears like kind of very often in this space. So sort of the attribution of mental health or substance use challenges to bad choices an individual has made. Right? And downplaying, again, the role of kind of social and structural determinants. So on the prevention side, those kind of the kind of general move away from blame and shame type framing. In crisis context, very specifically and explicitly not blaming and shaming clients for the crisis, which again, interview a lot of people. This is what one hears. This is often the on the ground experience, whether it is police, whether it's providers or other kind of staff or third parties who end up involved in the initiation of an involuntary hold. People tend to experience an awful lot of actually being blamed explicitly for what's happening. We can eliminate that. And then the same thing kind of when it comes to postvention in any kind of reflection or processing of the crisis. Police involvement, we really do just need to eliminate or reduce police involvement wherever we can. I was recently at a crisis conference where Ron Bruno, one of the founders of crisis intervention training, CIT, and a former police officer, retired police officer, was speaking, and he really kind of powerfully made the point that if the police are there, the police are there. Right? And that changes the tenor of what's happening. And I think he asked some folks in the audience who were kind of pushing him on this, right? Do you feel more anxious when you see an armed police officer in the room? If the answer is yes, we should be doing everything possible to remove police from the equation. And he's not a proponent actually of co-responder models, so where police and clinicians are paired for this reason. Policies and practices tied to risk. One more thing I'll say under police involvement specifically is that police end up involved in crisis situations in so many different ways for so many different reasons, and this is not their fault. This is the law. It's most often due to the way that state statute is operationalized. So, for example, if involuntary commitment petitions must be served by police officers, which is the case here in Pennsylvania, well, there is no option. There is one individual individual by law who can serve that warrant. Or if police officers are the only ones who can provide transport, even if they don't initiate an involuntary hold, if they're the only ones who can transport somebody who has been civilly committed between facilities, well, police are in the equation. And so I think we really kind of have to deal with laws here, what they are requiring, how they structure kind of intervention, transportation, et cetera, and thinking about it across the crisis continuum. Policies and practices tied to risk. So the pervasiveness of this kind of language and emphasis on risk, I think really starts to again kind of frame and color the conversations that we're having and the way that decisions are made. And in general, the empirical evidence on our ability to gauge risk is sort of can best be described probably as kind of condemnatory, right? We have almost no ability to actually gauge somebody's future risk in the context of kind of mental health or psychiatric crisis. So, kind of thinking about how this plays out, risk talk, risk discourse, risk assessment across this continuum, and rethinking that, or at least being open to rethinking that. And then medications. So, so both on the prevention side, we have got to address the toxic power dynamics around medication adherence. I do not think that they're benefiting anyone, even in a case where a given individual really might do better, quote unquote, on antipsychotics. Just an escalation of power dynamics, that's not going to get you there. That's not going to get to that person wanting to take those medications. It's actually going to undermine that. On the flip side, often what happens, the reality of civil commitment in this country is that it is kind of widely regarded and treated, and structurally so by insurance companies, right, as medication stabilization, rapid stabilization at that. So folks are very often put on multiple medications. Multiple antipsychotics are not uncommon, and often at really increased doses, even for an antipsychotic that they might have been on when they come in. Then there is little to no support given when they're discharged to either withdraw from all these additional medications that have been added or to taper down in doses. So I think we have to be very intentional about that, knowing the landscape of what happens, even if it doesn't align with the evidence, right? Antipsychotic polypharmacy, there's a huge literature saying we shouldn't be doing that. And yet, realistically, we see this happen in the context of involuntary hospitalization all the time. Knowing that's the reality, how do we kind of conscientiously and carefully support people in terms of discontinuation and tapering regimens when they're discharged? And I'll just add to that even when we remove psychosis from the equation, that a lot of the youth and families of youth I've interviewed, because of fears nowadays around, kind of benzo addiction, psychiatrists will often prescribe an antipsychotic to a youth who is literally only experiencing, maybe more severe anxiety or depression to help them sleep, and kind of basically to take the place of an anxiolytic because of concerns around potential for addiction. So I see youth getting discharged all the time, right, who have been put on an antipsychotic that is wildly inappropriate, just conforms to absolutely no available evidence that, that kids as young as 14 or 15 should be taking antipsychotics for anxiety, for example. So I think realistic about what it takes to sort of proactively address the regimens that people will have ended up on once they're discharged. All right, so now quickly just sort of a brief kind of concluding discussion and summary. So my perspective here, when it comes to people with psychosis, when it comes to the outcomes that we see, that's unacceptable, that 90% unemployment is unacceptable, that this incredibly excess risk of homelessness and incarceration in jails and prisons is unacceptable. That's unacceptable. That can't be the future for individuals with psychosis or for our society as a whole. And then, obviously racism playing out within that. I do not think top-down control strategies have worked. So, that does not mean, again, to repeat that there are not very real challenges and complexities. And I want to fully acknowledge that doing justice, what it would mean to do justice to people and to ourselves, is as difficult as it gets in this space. From my perspective as somebody who is also trained as a kind of philosopher and ethicist, right? It is really, really, really hard, and I do not want to downplay or oversimplify that. So we need complicated, nuanced challenges and solutions that are going to be multifaceted, that are going to have to cover many different areas. It's not, if we create peer crisis respites, problem solved. It's nothing like that. It's not, we have co-responders or we have mobile outreach, problem solved. Absolutely not. We really need to kind of think along this continuum in very kind of nuanced and granular ways about what we can start to shift and change. And that is all from me. Here are the references, for all of the sort of the empirical points that I have been making throughout the presentation. Thank you all so much for listening.